and um, the great tendency in organizations to blame the victims and to sideline the whistleblowers. So these are all serious problems within the organization. But as far as patients themselves are concerned, quite often they come with multiple problems, especially those who use the service a lot, which is defined as seeing a GP more than once a month. And many of those have MUS, which is short for medically unexplained symptoms, though the narrative medicine people say it ought to be called medically unexplored stories, which is a good teaching point, because sometimes that's true. And there's widespread concern about overdiagnosis, because if all you have is a hammer, everything has to look like a nail. But a lot of things don't fit into the diagnostic categories that we have in conventional mainstream biomedicine. But overdiagnosis leads to overtesting, partly driven by fear of litigation and overtreatment. So many people are voting with their feet. Even people who can't afford it are being not even gently pushed towards the private sector when they are frustrated by a long waiting list. And other people are, again, if they have the spare change, going to complementary and alternative medicine practitioners. So that's the setting in which we get these interweaving crises. It's costing too much. It can't cure chronic disease, or can't do much, although it does marvelous things for catastrophic and acute disease and injury. The system itself is making it hard to care, and the data we have on early retirement or escaping the NHS entirely or becoming a pharmaceutical rep or a banker, I mean, anything but a junior doctor, show that commitment and vocation is not what it was. Spending, even with the new government, is flatlining. Disappointing words from Keir Starmer on the what's needed to be done before funding can follow. So there's got to be reforms without funding, and I don't see in his three criteria for more funding and for reform anything about the front line, anything about practitioner support. The NHS is its staff and it is its patients. The NHS has 1.5 million staff, the fifth biggest employer on the planet. Of those, about 750 odd thousand are professionals. So here we are, after years of austerity. We're very, very short of expecting funding and funding targets, but there's more demand than ever. There are more old people, the population is growing, and this is not a recipe for a more, or rather a less demanding service that is going to allow practitioners space to breathe, which is what we need. So patients and staff are paying a very high cost. And clearly, need I say, we can't go on like this. For the doctor or the nurse, and we're short of 100,000 or so nurses. God, this is turning into a terrible bad news show, isn't it? I hope we can have an uptick in the optimism a bit later on. So where is the art of medicine gone? Is there any place for it in medical education? What is health? There's not a lot taught about health in medical schools. Values, purpose, meaning. That's a bit old school. Does the system value me? What are the system's values? Are they at odds with my values? Do I feel valued? If resilience is doing a decent job without it costing too much personally, am I resilient, or am I going the extra mile and burning out? And why have I lost interest in healing and helping? So all that's in the background. We surveyed medical students, not many, not more than a couple of hundred, many of them in Scotland, And we got some very suggestive findings. What more than half think that there's nothing about practical nutrition, nothing about social prescribing. In other words, how do we expand the possibilities for particularly doctors in the community to refer to charities or for exercise or for cooking classes or for walks in nature, all that sort of social prescribing that's come up the highway in the past 5 years. Nothing about community empowerment and health champions. Nothing is yet about personalized care, which is a peculiar term, which means everything from high-tech reading of your genome to having choice about how you spend a healthcare budget. Lifestyle, even now, very little about lifestyle interventions in medical education. The idea, for instance, as well about group consultations, where the patients in a group become the experts in their own condition. Nothing much about community health and public health. Very little about arts for health, although that's a huge resource, which we've been working with for the last 5 years. Medical schools who are using arts to explore the particularly more difficult encounters that students have as they go through medical school. And then green prescribing, the whole. Hello. Turn your mic off. Microphone, please. Microphone off. Thank you. And as yet, nothing about green prescribing. The use of. I hate the idea prescribing nature as if it can be as if it's a commodity, but it's a step on the way towards a stronger link with the other than human world, which we know has health benefits. So, any questions at this point, or we'll have the first breakout. So if you've got any questions, just whack on your microphone and speak up now, or put something in the chat box and we'll come back to you later. Okay, so the idea is we're going to have, oops, there's going to be a noise now, hang on. Hopefully everyone in the room has had a good encounter, maybe several good encounters with the NHS, and we'd like to hear from you in a breakout room for about 10 minutes, have a chat about that, and then at the end of it, could you come up with 3 words, each person comes 3 words, whack it into the chat box so we can make a word cloud about why it went well. And I'll join one of the, I'll certainly join one of the chat rooms. Are we pretty clear about that? That's what we need, 3 words in the chat box, but the conversation's important. So Gail, can you make the chat rooms?
Yeah, I'm going to create 4 breakout rooms.
Okay.
Now, so everyone should go off.
We've got quite a few more people in now, I think 13, that's good.
There we go.
Thank you very much. So I'll come back to the share. And what's that one?
David, are you asking people to share some words in the chat now?
Yes, if I can just put, 3 words if you can in the chat to summarize why that particular encounter with somebody in the NHS. I kind of meant it to be patient doctor or patient nurse, but it might be colleague to colleague. Just give yourself a few minutes to find, not for the whole room, but you in particular, what you felt were the key elements. And then rattle them into the chat box so we can get 2 word clouds out of this. So I've got from Lalo, gratefulness, appreciation when something goes well. Are you're still struggling with your 3 with your 3 words? They don't have to be the right words, just whatever's just coming through intuitively without overthinking it. I'm just hoping this slightly focusy group aspect of our meeting will be useful. Because there's very little work done on this kind of testimony about some of the really great work that goes on in the NHS. We often forget to thank those people who've made such a difference. Honored my wishes, listened to me, yeah. And often it seems that it's not what someone does for you, it's how they made you feel that's unforgettable and that changes your whole experience. It's definitely the art of healthcare that we're talking about here. Thank you, Maya. You've given me, listened to me and honored my wishes. Okay, I won't labor the point right now, but we do want to try and create this word cloud about our experience. Right. Well, and now the other side of the coin. What about the kinds of encounters that are not so fruitful, are unsatisfactory? Let's just give this one. Let's just give this 5 minutes, because I'm keen to both generate some sort of data from our experience, but also I want to move on to some solution finding.
Sure, I'll just put you all in now and bring you back at 44 minutes past.
Okay, thank you.
Thanks.
We're going to do room 3. Thank you. Welcome back. We've lost a couple of people, but we've still got 11. There's still 11 of us. So shall I get you to carry on? We'll just we'll do the PowerPoint share.
Do you want to capture the words?
I very much want to capture the words. Yes. Yeah. 3 words from each person to summarize why things didn't go too well. And then we'll have 2 word clouds.
David, I don't know if it's just me, but maybe other people are having issue with the chat. I seem to have the option to either send it to the admin or to you personally, rather than just send it to the whole group. So would you like us to send it to you personally?
I think send it to Gail. Send it to admin.
If you can send it to admin. Sorry, I'm not sure what's going on there.
It might just be me.
No, thank you. I think it is a bit funny. I had the same problem for a minute.
Yeah. So we're not ignoring you.
Thank you.
Let's just come out of there. Okay, let's see. Yeah. I'm just trying to check that I've managed to send to you as well, Gail. But even if we don't, has everyone had a go at sending their chat through to Gail?
I think we're getting there. Maybe a couple more. Maybe.
I've lost my chat thing.
Yeah, here we go. Thank you, Millie.
Yeah.
Just got that.
So at some point, I hope we get that. This is not the word cloud. This is just a sample of what a word cloud can be like.
I am making them, so let's see what we can bring up. Let me just make this smaller. Did you see the link in the chat that I sent to you, David, the document?
No, not yet.
It's fine, don't worry. Now, what's going on here? Oh, but that's technical challenges.
So at the moment, I've got the beach ball of death is rolling across my screen, telling me that something's stuck.
Don't worry, I'm making it. Oh, there's another one. Thank you, Maya. I'll just
yeah,
yours, and then I'll.
Can you see my slide now?
Yes.
Okay. So we surveyed these medical students. About half thought, yeah, that was okay, and a third felt no, it isn't working for me. There was some of the data was around how they weren't really being told about how great a difficulty the NHS is in, and they certainly didn't feel that they were being given the kinds of encouragement to be part of the solution. A surprising number felt that they weren't being taught critical thinking and to be able to discuss the future constructively, which is odd in what ought to be an academic course. Half didn't feel they had a say on what was being taught, and a similar half didn't feel that they were trusted by their institution or that they trusted them. And one quote is on the screen, not that anything's being left out, just that the people they're being taught by, this is kind of tragic, isn't it? Burned out doctors trying to prepare us to work under an unsustainable system, which has become so much worse over the years. I've been at medical school. I still want to be a doctor, but to a certain degree, I'm dreading work because the system is relying on doctors being under so much pressure they'll break. The system has to change. It's not an acceptable thing to expect of people. And 3/4 or so said that their mental or physical health had been compromised in the process of getting through medical school. And a very small number felt they were actually enjoying learning medicine. And only a half, I'm surprised it's not more, said they hadn't been given tools for resilience. Not that I'm sure that tools for resilience is a good term, as if there are these magical fixes, but there are certainly many things that we teach in our curriculum which are effectively support flourishing. So the future, well, there's not a lot of hope there, but then that's reflected, I think, in Generation Z's profiles anyway, that they don't, the youth don't feel there is a future. Somebody once said to me, "Do you remember the future?" I said, what do you mean remember the future? Very funny. Did you remember tomorrow's world? We were going to be flying around in hovercraft and there'd be kind of tourist trips to the moon and unlimited, yeah, that future. Yeah, no, we've definitely forgotten that kind of optimistic future. It means medical students are left worrying about these issues on their own, including climate change. It feels like it's an issue that's being avoided because they don't want to put us off medicine, but we're all aware of it anyway. So there's a bit of that kind of don't talk about this in front of the children feeling, isn't there? Which is really not how we're going to help our young ones get to be part of the solution. Back in 1984, we created the Holistic Medical Association. There was a one-year cooperative inquiry run by John Heron and Peter Reason. Peter's talking at the conference, by the way, for those who are coming. And there were 5 points that emerged out of the inquiry and that people tested out in their own practice as the year went on. So mind, body, spirit in context, of course, that we are self-healing and probably to a much greater degree than we realize. But how do you make that happen? Power sharing, really important, not just good communication techniques, but the whole possibility that, yes, if I'm under a bus, take control, doc, and put me in intensive care. But if I've got a chronic illness which is lifestyle related and I'm living in near to a road that's poisoning me, then I need a whole other approach, and I have to be much more engaged with my own self-management. Those sorts of things. Wide range of interventions, not just based on sharing power and information, but what are mind interventions? What are spiritual interventions? How do you work with meaning, for instance, and the distortions of meaning? How do you perhaps help someone to construct new meanings? That's on the spiritual dimension. Lots to say about that. And should a holistic doctor or nurse have access to some kind of alternative therapy? Whether or not, this is my opinion, because I've spent years kind of collecting every therapy under the bush, under the sun, including osteopathy, acupuncture, and homeopathy, all of which have gone, I've left behind now. But yes, I think to have different intellectual, if you like, worldviews, goggles, whether it's Taoist, whether it's Ayurvedic, whether it's Hahnemann, whether it's still, just to have a different view of how to construct your narrative about what's going on. It is very, very useful. But above all, I think the practitioner needs to look after herself. If you want to be a whole person practitioner, work on becoming a whole person. And that should begin at medical school. Because the kids who come in, they don't know what they don't know. And it should be up to us to say, number one, you're walking into an emotional minefield. And secondly, you're going to be very, very extremely challenged as you move through a 50-year career. And there are a few things that you need to know about. So that was and still remains our motto: "The physician, heal thyself." which is, I think, from St. Luke. Is it one of the Gospels anyway? And is really an important thought because, not to get too Jungian about it, now people come into medicine often because they have wounds of their own, and that needs to be looked at too. I'm going to move on and just say a little bit about what the bigger curriculum might include. But any questions? Anything we need to discuss at this point? Okay, moving swiftly on. There's so much science around the factors that create flourishing and well-being and impinge on established disease. So, in no particular order, subjective well-being, and not only that, but is well-being, am I in an I society or a we society? Because generally speaking, we societies have a better subjective well-being. Particularly relevant to the NHS, leadership, work culture. The NHS, because it's under so much pressure, can bring out bullying tendencies. And it's a very hierarchical structure too. And those cultural moods are not good for the people working in them. It's difficult to be compassionate in an uncompassionate organization. All that we know about what Antonovsky called coherent communities suggests that empowerment, high degree of social capital, communal engagement and enthusiasm for working together, these really influence subjective well-being, but also, I think, probably create a sense of relative communal calm, so that adversity doesn't necessarily send you and your neighbors into a spin. Now that, of course, is completely at odds with our current landscape of social media and our inability now to distinguish falsehood from reality, and the freedom it seems we have now as members of online communities to say bad, untruthful things about one another. This is not good for the species. Yeah, there's a whole world of eco-psychology, our relationship with the human world, everything from forest bathing to earth-centered spirituality, and sort of the return of spiritual engagement with the world that we are a part of, not apart from. And more obvious mainstream stuff, nutrition, of course, public health, good policies around, well, yeah, many of the advances in early 20th century medicine were due to plumbers and working men's education groups, and all the things that made for safer living environments. Still, with the Second World War and the advance of big pharma, antibiotics, vaccinations programs, and we begin to see medicine itself being much more in the driving seat. But really, in the background, we are as healthy as our environments and as healthy as our diet. And the question of sustainability, what's good for the planet is good for people. And I think vice versa, walking more, eating down the food chain, these are good for the planet and they're good for folk. Good communication, certainly, I hope we've got some evidence of what's a good consultation like, a good encounter, and what's the other kind like. And it's very much about a meeting between human beings that is full of a sense of being trusted. That came up in our conversation, that one can be vulnerable and safe at the same time, but also that in our communication, we create more or less therapeutic stories about what's going on. What's wrong with me? Maybe somebody saying, well, never mind what's wrong with you. What happened to you is often a much more relevant question than what are your diagnosis. Both are important, of course. And there's a whole world now of evolutionary and interpersonal neurobiology. We know much more about the nature of the physiology, the embodiment of emotions, the stress response, why stress is inflammatory, what stress has to do with depression, heart disease, immune function. The idea that the mind and body are not a unity is very old-fashioned now, far from scientific. Then there's all the stuff that I think is much more interestingly dealt with in the alternative systems. The nature of typology, character. These are at the heart of a lot of Chinese medicine, East Asian medicine, whereas we don't deal much in the idea of temperament, although coping style is interesting. So psychological types, but not much about a physiological type. So that takes us into genomics and epigenetics and those sorts of psychophysiological categories that do distinguish different typologies, but somewhat objectively, rather than the more qualitative ways that we get in the Asian systems. And then finally, all that one can do around self-care, psychological and behavioral lifestyle interventions, a whole range of non-pharma interventions, which was my research area before I got into this Dr. Burnout bit. Mindfulness, CBT, the role of exercise, nutrition, art, stories, music. So there's a huge amount that is fundamentally missing from the curriculum. And it shouldn't be, because here we are in a society that thinks of us as individuals, which is only partly true. And you can divide that individual into body parts and organs, and get smaller and smaller, get quite reductionist in that. And you can learn a lot, but on the other hand, we're also in these much larger layers of the onion. And every layer affects every other one in both directions. So it's complex, and medicine needs to embrace that complexity. So what are we up to? Well, we'll try and get some more data on what the students and junior doctors say is missing. We've launched our holism course. Not a big uptake yet, but we've had some good feedback on that online course. We've been using the journal as an inspirational showcase. We're trying to reimagine medicine through the lenses of people who are actually doing it in or near the system right now. And our conference in October is all about that kind of innovation. We've got a free access to the journal project for students, nursing and medicine. And we're reaching out into the medical schools. There are some brilliant medical teachers there. Two of them in particular, professors, Louise Uni and Trevor Thompson, who are doing great work with art and the humanities to help their students dive down a little bit below the surface of words into the experience of being in a difficult or an inspiring patient encounter. And the comments we've got is, as medical students, we're overburdened. We're being assessed and so many things. We're cramming. There's no space for personal development. And we see, as Generation Z, the need to create boundaries to look after ourselves. And really, the way the curriculum is organized is in conflict with this instinctual feel that this next generation has for getting not work-life balance, but because these aren't two separate realms, but for getting some kind of balance between the area I call education and work and training, and what's needed, both in tools and time, in order to grow a larger sense of self. So that's what we're up to. We're questioning the hidden curriculum because so many aspects of medicine are perpetuated through role models. And as one person said, and I quoted before, we're being taught by burned out doctors how to work in a burnt out system. It gets a kind of slash and burn, really. Our young doctors need to understand how to create and sustain health. And a lot of that is definitely not biomedical. And the curriculum is still stuck in the old mind-body split. And that really does have to change. So those are the areas we're working on, in particular through our course and our membership and our events and our journal. So I invite you all to take a look at we've got 20 years of free archive of the journal available even now, and the print edition is a thing of beauty. So thank you for still being with me, and let's have a conversation. Any luck with the word cloud?
Sure, let me share my screen.
I'll copy this to you.
You see, I was trying to get them both on the same screen.
Okay, tricky. I've got a bit more data for you here from my own encounter with a very bullying gastroenterologist, no names. Not what you want when you're having a colonoscope. You mean doctors have colonoscopes? Yes, because we have colons. Yeah. We're not perfect.
Let me see if I can put those images in the chat. Sometimes it doesn't work, but let me see if I can.
David, whilst we're doing all this tech behind the scenes, may I ask a question?
Yeah, go on.
Well, as someone I haven't been to medical school. I'm training to be an osteopath, so only 4 years compared to however many years the medical training currently is. But even with the osteopathy training, there's such a, it's never ending what we need to learn and understand.
Yeah.
And I can appreciate that, especially in a medical curriculum, there's probably this sense of intensity of having so much to learn. So how would you recommend that curriculum being rethought to allow that breathing space for students and practitioners to have that time to look after themselves? What would be your healer? How would you fix it?
Well, first, I wouldn't teach medicine in teaching hospitals. I'd teach it in the community, probably as an apprenticeship, probably with the offer that if you are apprenticed in the community, learning in general practice on and with patients who have all the conditions you see in the teaching hospitals, with their testimony, hearing their stories, being in both a potentially problematic, but also a very, very nourishing way in the community, knowing that if you stick with this, probably 4 years of a community-based medical curriculum, you'll be offered a post in that area. So localized, relatively small scale. I think if then you want to go on to a specialty, to be a specialist, you go into that specialty actually knowing something about human beings, far less about perhaps the biology, not far less, quite a lot less, but enough to, certainly you'd know enough to be a good GP, given the kind of the postgraduate part of the studies. You don't stop learning in medicine, but the bones of primary care practice, I don't think require 5 years of teaching in a teaching hospital. Let me tell you, in a month, any 1 month, 750 people get a symptom. Of that, about 250 go to a GP. Of that, about 10 go to a hospital outpatients. Of that, 1 goes into a teaching hospital bed. That's the one we learn about medicine from. What could possibly go wrong? Yeah, so it needs completely turning on its head, and that's not just me. I mean, very influential people like Professor Sir Sam Everington, who's a nice guy. He's pushing for that. The problem is, in the upper echelons of curriculum development and the empires that are represented by senior teaching hospital people, there's very little representation of general practice on those panels. So at the moment, the turf wars are always lost by primary care. Now, Keir Starmer says he wants to move things into the community. Let's see what happens. Partly because if he's not quick enough, there won't be any community. So, yeah. And I agree with you about, I mean, having done my medical training and an osteopathy training, although it was short and sweet, it wasn't much more than a year. You folks do an immense amount of anatomy and physiology, and I know you're expected to be absolutely faultless in that knowledge. But you earn masses more too, don't you? Do you learn a lot of psychology as well?
I wish we did. I mean, we have had, I think it changes from curriculum to curriculum. We did have a supplementary course with motivational interviewing and kind of the elements of how we can encourage ownership of change and work collaboratively. But it does tend to feel like a bit of an add-on. But and having been in student clinic, it's those tools that seem more pertinent than, the mobilizations themselves. Because I think from the year I've had of experience in that clinic, the people who feel sort of empowered to go and make the changes themselves are always the ones that get better.
Absolutely. Yeah. Absolutely. And those who want to keep come back and see every week are the ones who are not going to get better. Yeah, all too often anyway. Not to generalize too much. Anybody else want to raise a hand or chat about this? Can I have maybe a show of hands? Because I'm kind of an elder in the trade now, and I see both its brilliance and its wounds. I hope I haven't presented it as too badly wounded to be rehabilitated. Have I been too pessimistic, too down on the future? Give me a thumbs up if you think I'm not too far off the right track. No thumbs up. Oh, there's one. There's two. There's Aisha.
There were a few thumbs up then, yeah.
Okay. All right. Have you got a word cloud?
Yes, I can't put it in the chat though, so let's go back because I did add the.
You could email it to me if you like. Or...
Yeah, I can. I will do that afterwards. But this is what it's looking like now.
Oh, that's very good. Shall I have you host? Do you want me to give you host for a minute? So we can see it large.
Or you want me to make it larger?
Well, I could give you hosting, so you could screen share.
I am sharing my screen. Can you not see it?
I can see it, but it's quite small. Oh, I don't know what I need
It's
to
because
do.
it's in a Word document.
I've got it now. I've got it in 100% now.
There we go. So that's
Listen, wish, honoured, something. Appreciation, reassuring. Right. Okay. Sort of no surprises there, but it's good to see all that. What about the not so good? Ignorance, waiting, argumentative, misdiagnosed, delaying, iatrogenic, unheard. Okay, I have to give you my 3 words, because my 3 words were bullying. What were they? Bullying, unsympathetic, and dissociated. Yeah.
I'll add those
Yeah.
to it and create another one then in this document.
Yeah. So here we are, folks. We've got another 10 minutes or so. I've really said what I need to say and presented my experience, such as it is, and our intentions. We just to look up a little bit. I found the new generation of medical students are really keen to be shown a better way. On the other hand, if I look down a bit, I actually see that the system is not creating a safe container or giving them the resources to work in a better way. And so I fear that those doctors and nurses who really want to work in a more integrated way will do what they've often done, which is move into the private sector or jump ship and go and work in New Zealand. So I really want to encourage people to find fellowship with BHMA and others, and we'll be setting up support groups with that in view, so that they can survive and eventually thrive. Because I think being able to be around other people who share your concerns and are working together to be part of the solution is really, really helpful. Any more questions? I'm going to stop pontificating now, and we'll close the webinar if there's nothing else to explore. Well, Millie, Sheila, Siri, Gail, it looks like, and Maya and Sarah and Lalu. Thank you for coming, and give us any feedback you'd like to. Join the BHMA if you can possibly do that, because we need your support. And look out for further webinars and a whole series of interviews with some really wonderful practitioners who are making great waves and doing really fabulous, innovative work in or near the system. Oh, and the conference is online as well as being in person. The in-person conference is full, but we've got a good online offer, which will be a bit like this, with breakouts and lots of time to be participating. October the 5th, be there or be square. Okay, folks.
Thanks ever so much, David.
All right. Thanks, Mary. All the best.
Cheers. See you soon.
Thank you. Bye.
Bye. Do you want to stay on, Gail?
Sure.
Well,
just need to. Sheila, are you, and Lolo and R, are you all right to drop off?
I think they probably have dropped off. Possibly dropped.
Don't know whether people have jammed. I'm just going to close it, David. Can you join again? Is that okay?
Yeah, sure.